Okay, great. Thanks very much. You can hear me there, Eagle Ridge? I can tell? Yes? Good? Okay, great. Thank you. Okay, so I'll get going and just start by these learning objectives are actually on the invitation, but I wanted to I'll just flash the slide quickly and then I'll tell you a little bit about what I'd like to do during this presentation. And I just initially wanted to give you a little bit of a perspective of the incidence of massive transfusion episodes across Fraser Health, and then we'll focus on Royal Columbian Hospital. And I want to touch on massive transfusion protocols per se, just what are probably the critical elements of a protocol. Then I've got a fair bit of data to show you on an audit that we've done of the massive transfusion events here at Royal Columbian over the last year. And finally, or next to last, I guess, I wanted to talk to you about some work that we've been doing over the last year in terms of developing a pre-printed order for massive transfusion that will be a regional pre-printed order, and it's relevant to you in terms of understanding how the patients are going to come to you from the wards and the emergency room and so forth. And also, I think the principles will be the same for the work that we'll be doing on a similar protocol for the operating rooms. Then, if hopefully time permits, I was asked to touch on what's available at Eagle Ridge in terms of resources for this type of event. And I wanted to talk a little bit about coolers, if we have a chance, okay? So just a quick look at events that have occurred in Fraser Health over the last, in 2014. And really what we did is we took the historical definition of massive transfusion is greater than 10 units in a 24-hour period. I'll touch on that definition in a couple of minutes, but just looking across the region, what we're not really able to capture the patients who receive more than 10 units in a 24-hour period, but we could capture patients who got more than 10 units in a calendar day just through pulling data from Meditech. So you can see fairly obviously that RCH has the bulk of the massive transfusion episodes with 69 and Surrey at 9. This is where they started. Abbotsford 9, Burnaby 6, Eagle Ridge 5, and so forth. And you can see also that a number of these patients were then transferred to RCH. So 14 of the ones that didn't start here were transferred to RCH. Okay, so just a quick idea of where they're coming from at RCH. 32 of the patients were in emergency department, 18 in ICU, 7 cardiac surgery, 6 surgical, and so forth. And that pattern is kind of repeated across the region. Most often this is encountered in the emergency department. I think it's where they start, actually. Yeah, I think I've got another slide later that'll perhaps address that question. So I just also wanted to talk briefly about what I'm proposing as part of our regional pre-printed order as a revised definition for massive transfusion. And I mentioned this historical definition of greater than 10 units in a 24-hour period. And that is not particularly useful for a variety of reasons. Another definition is greater than 1 blood volume in a given time period and so forth. But these are sort of arbitrary and retrospective definitions. They're subject to survivorship bias in that patients who require intensive transfusion initially may not live 24 hours, and so they would not be captured as a massive transfusion event per se. And this definition doesn't really reflect the intensity of resuscitation at a given point in time. And when I show you some of the data from RCH, you'll see some patients who got more than 10 units in 24 hours, but it was a gradual thing over a 24-hour period. So not the same as the kind of patient that we really, I think, all understand it represents a massive transfusion. So there are other definitions that are out there. This is the one, the bottom one is the one that is currently on our regional massive transfusion protocol. So same kind of thing. You're trying to predict blood loss, and it's a less objective measure. So this concept was advanced in this paper published in 2013 from Texas in the Journal of Trauma and Acute Care Surgery, and they defined what they called a critical administration threshold of 3 or more units in a 1-hour period. And they reviewed 169 trauma patients who had received transfusion in their first 24 hours of admission. And patients who had this critical administration threshold were 3.6 times more likely to die than patients who didn't have this threshold. And they compared that to the traditional definition of greater than 10 units in 24 hours. And this was basically twice as sensitive for predicting these events. So the advantages are its prospective and real-time identification of patients who need aggressive resuscitation. And probably it's a better reflection of the intensity of transfusion. And I think it will be an objective, useful trigger for the activation of the massive transfusion protocol. So just to touch on what, I think so people don't necessarily confuse the idea of a massive transfusion protocol with ratio-based transfusion. The protocol is really a set of processes to avoid system delays in provision of blood components. And it involves the ordering, the processing, and transporting of blood components. And it also involves expedited turnaround time in the laboratory. So you're all familiar, I think, with the fact that this is how we run our protocol here at RCH. And then the other advantage of this is that these mechanisms are designed to achieve early provision of a more balanced ratio of plasma to red cells and platelets. So this is old. This is the original. When I developed this in 2004, we didn't have the regional program structure that we had until recently. So in the interim, and so really it was written as a laboratory guide to massive transfusion, and we wrote the procedures for the protocol in the laboratory, and this has sort of become it's a framework to overcome a lot of the delays that had occurred historically, and in terms of getting blood components, and I'll touch on what that entails in a second, and so it has actually become the de facto massive transfusion protocol for Fraser Health. So it's posted on the internet. People have trouble finding it. It's the laboratory guide to massive transfusion. What I'm going to touch on in a short while is something that's more clinical and laboratory oriented, and that's the pre-printed order. And but we did update this regional protocol in 2010 and 2012, and we began piloting a modification of the protocol at RCH in the emergency department in particular. So in consultation with trauma, we developed a protocol that was intended as a pilot for 1.5 years, and it's gone on now for 5 years, I guess. And we do continuously update the laboratory procedures, which really form the basis of how we respond to the massive transfusion events. So this is what we do when you activate the massive transfusion protocol. So here at RCH, and if we've issued 2 or 3 units in rapid succession, we'll usually ask if you want to activate the protocol, and so that's one of the things that we do, and the other things we do now is proactively thaw plasma. So historically, you might encounter this, let's say more than 10 years ago, you might encounter a massive transfusion event, and people don't necessarily think to order plasma right up front, and so the 20 minutes that it takes to thaw plasma is an additional delay when you when the order is placed, for example. So what we do is we proactively thaw plasma. We ensure that 2 platelets are available on site. So there's almost always platelets here at RCH. It's the largest service in the health authority, and we've pretty much always have platelets unless somebody's used them up in the previous couple of hours. So, but the other sites, Surrey stocks several units, Abbotsford stocks a couple of units, but the other smaller sites like Eagle Ridge and Ridge Meadows, Langley, Peace Arch, they don't have platelets on site. And that's because platelets have a 5-day shelf life. They're stored at room temperature. By the time we get them, they only have 3 days left. So, you know, they're just, we don't have the resources to stock them at all sites. So that's one of the first things that they're meant to do, is to ensure that the platelets are available on site. Historically, there was a requirement for people to order the blood components in Meditech. Once the protocol is activated, we accept verbal orders. We issue multiple red cells at a time, because normally we don't. Normally we'd issue one at a time, for example. And we bypass all the usual audit criteria. So in a non-MTP scenario, when you order plasma or red cells or platelets, the technologist checks the counts or the lab values, and they consult with us if they're not sort of within certain defined criteria. The other big thing is to expedite the turnaround time on lab results. So in these critical events, the patients often have very abnormal lab results. So when the normal practice in hematology, when the platelet count is very low, is to review the slide before releasing the result. And in the MTP, they release the result before looking at the slide, right? Because it's expected. And that had led to delays in the past. The INR and PTT, for example, can be very abnormal, and the same concept. In that case, we would often question how it was collected. We would ask if the patient was on heparin. We'd rerun it and may ask for a recollection. But in this context, we just report the results verbally. Okay. So what's different about the RCH protocol in Emerge, okay, is that the TM staff track the issues. They track the ratios of the red cells that have been issued, the plasma that's been issued, platelets, and so forth. And the goal is, this is what the goal was when we wrote this in 2010, and that's to ensure that the patient gets a foundation ratio of 1 unit of plasma for every 2 units of red cells, and a unit of platelets for every 8 of red cells. This is going to change going forward. The ratios will be different, perhaps. And then we actually issue cryo if the fibrinogen is less than 1 gram per liter. Okay. And then the other thing about the RCH-ER protocol is that there's an order set for these patients, that they have blood work every 30 minutes for the first 2 hours. The ER doc still has to order the red cells, and they order additional plasma or platelets as required. Okay. And this is what it looks like, and I know you can't really see that, but I just wanted to show you this. This is what it evolved to. The 2012 modification included the addition of tranexamic acid and some other minor changes. And this is really just, I think, what may evolve in terms of what's best for the operating room in terms of an emergency care plan or critical pathway kind of thing. So just now I want to touch on the audit that we did over the last year of the massive transfusion events. And so we tried to identify, at RCH, when a massive transfusion protocol is initiated, we have a communication log in the blood bank. We track the products and so forth. So we pulled all of those, and we also looked for patients who received more than 10 units in a calendar day. So in doing that, we came up with 140 records, 144 patients, 39 of whom were transfused more than 10 units a day. And then we looked at, of those 144 records, 7 of those 10 unit and 24-hour patients did not have an MTP activated. So we excluded those because we wanted to look at how our MTP performed, right? And those 7 patients included cardiac surgery, who bled over a period of time, and protocol wasn't activated, and a GI bleed, who bled over a period of time. So we were left with 137 records. We then applied this criteria of 3 or more units in the initial 1 hour period. And so we excluded 36 patients. I'll show you a little bit about what they look like. So we were left with 101 patients who had the MTP activated and got more than 3 units in the first hour. So these are the patients who we excluded, who had MTP activated but didn't get 3 or more units in the first hour. And it shows the number of patients in the vertical axis, and the total red cells that they were transfused over the 24-hour period. So you can see that many of these patients either got no red cells or a small number, 4 or less, for example, 5 or less. And then yet there's individual patients out on the right there that received more than 10 units in a 24-hour period. But these were MTP activated, but they didn't receive more than 3 or more units in the first hour. And here's a look at those patients. Of those patients, there were 2 patients really. Patient number 1 and 4 were both obstetric hemorrhages that were transferred in from other sites. So they got their initial red cells elsewhere, and we didn't include them in the audit. If we had a different mechanism of auditing, we would have probably included those patients. And there were a couple of other patients here that started here were bleeds that exceeded 10 units in a 24-hour period, but didn't meet that 3 units in the first hour criteria. So this is our primary cohort of 101 patients, and I described how it was defined. And we looked at the components issued immediately prior to the activation of the protocol in the 60 minutes prior, and at each interval of 0 to 30, 30 to 60, 60 to 90, and 90 to 120, and then within 24 hours. And we wanted to assess, our ability to deliver these products quickly, and our ability to achieve a foundation ratio of 1 unit of plasma for every red cell, 2 units of red cells. And that's been the basis of our protocol since the beginning. It's actually something that was endorsed by the Canadian Consensus Conference on Massive Transfusion in 2011, and that is that the important thing is to ensure that you don't fall behind initially, and so that's why the foundation ratio is important. Certain patients, and trauma in particular, may require more aggressive ratios in the vicinity of 1-to-1 ratios. And the reason for that is they have a different type of coagulopathy than your typical massively bleeding patient. They have activation of fibrinolysis and other aspects going on. So here's the location at the initiation of the massive transfusion protocol in these 101 patients, 60% in the ER roughly, 20% in the OR, and 17% in ICU. And I had another slide, I think I dropped it because I had too many slides. But some of those patients from the ER shifted to the OR or to ICU. Okay. This just shows you the components issued, by time. So this is issuing from the TM. You can see that the red cells, the average number of red cells is substantially higher than that of plasma and platelets that are in the blue, light blue. And then as time goes on, you can see at 0 to 30 minutes, again, we're starting to catch up a little bit with the plasma and the platelets. At 30 to 60, we're doing a better job of catching up, with platelets and plasma. And then, in that, so it goes from there, basically. It's fairly straightforward, I think. And this is, if you lump that data together, if you look at the prior to initiation and the initial 2 hours, these are the sort of components that we issued on these the average numbers we issued on these 101 patients. And that's in the subsequent period of 2 to 24 hours on the right. So we wanted to look at the ratios of red cells to plasma during those various intervals. And this shows you that prior to the initiation of the protocol, there's quite a high ratio of red cells to plasma issued. And then as we progress through the time period, we're getting more and more plasma into the patient, and the ratio is falling. This is not a cumulative ratio. I'll show you that in a second. Well, here it is. So this shows that we're doing a pretty good job of issuing plasma and red cells in reasonable ratios once the protocol is activated and during the subsequent period of time. When you look at the cumulative ratio, which means including this pre-period where they got some red cells, you can see that we're not getting to, it's taking us 60 to 90 minutes to get to where we want in terms of a foundation ratio. And then this is just another way of showing this in a way, and this is the cumulative proportion of patients who received ratios of either 2 to 1, which is the top graph, or 1.5 to 1. So over time. And what I had was hoping to do was sort of do a kind of a reverse Kaplan-Meier plot, but it didn't quite work out. So in any event, you can see by 30 minutes, about 43% of the patients in this group, we're going to refine this cohort in the next few slides, but achieved this 2 to 1 ratio within 30 minutes, and it continues on up to. And then the 1.5 to 1, you've got about 17.8%, and then about a quarter of patients achieving that ratio by 60 minutes. Okay, so out of that cohort of 101 patients, there were a number of patients who didn't get plasma at all, and there were 19 patients actually, and 12 of those patients died. This is part of the problem with the the retrospective studies on ratio-based transfusion thresholds, that those studies had a number of patients who died before too soon to receive plasma, basically, and they're all traumas. It shows you the number of red cells they received. They got no plasma. There were motor vehicle accidents, pedestrian stabbing, or pedestrian struck stab wounds, and so forth, gunshot wounds. So these are patients who died. I'm not sure. I haven't analyzed them in detail. Whether plasma would have made a difference if we. But I excluded them because I'm wanting to try and test. Once we activate the protocol, how effective are we at proceeding? These are the other 7 patients who did not get plasma. The protocol was activated. They were non-ER patients for the most part. Okay, so we don't have, for the non-ER patients, we don't have this push mechanism of delivering plasma. We wait for the order to come to us, basically. And there obviously may have been clinical reasons why they didn't order plasma. So some of these patients didn't get a lot of red cells, right? Only maybe one. And these are patients who got 11 red, that ICU patient got 11 red cells over 24 hours. So, presumably they were monitoring the coag and so forth. And, okay. Yeah, it is. Yeah, lots of red cells. It's good for pneumonia. So, we took, I mentioned, now we have this cohort of 101 records of MTP activated and greater than 3 units in the first hour. I excluded those 19 patients who got no plasma, okay? And I looked at that cohort of 82 and then broke those into patients, the trauma patients and the non-trauma patients, okay? So hopefully I can get through this. So I'm moving now to cumulative components, and in this graph, and just showing this is the group of 82 patients, excluding those 19 who didn't get any plasma. And this is the cumulative ratio as time progresses. So initially, you can see they're getting an average of much more red cells than plasma or platelets. Then at the 30-minute interval, the 0 to 30-minute interval. Are you able to see that back there, or is it the light? Oh, you can see it? Okay. So, and then at 30 to 60 minutes, we're starting, we're seeing the same kind of thing I showed you with the previous data, that we're catching up over time. And this is the ratio in this group of patients. This is the ratio of red cells to plasma issues. So these ratios are a little lower than the group of 101 cohort because we've excluded the patients who didn't get plasma. But initially, prior to activation, they're not getting much plasma, and then, which is probably just a reflection of the time that it takes to recognize the episode and order the plasma or initiate the protocol. But as time progresses, the components we're issuing in more balanced ratios as time progresses. This is the cumulative ratios. So when you include that pre-activation period in the red cell count, you can see that it's taking us, we're making headway, but we're not achieving that foundation ratio for about 60 minutes or so post-activation. And then this is just showing the same information excluding the pre. It's cumulative, and the count includes the pre. Actually, I think it doesn't. It doesn't include the pre. So this is basically the ratios, the cumulative. Once the protocol is activated, these are the ratios that we're achieving cumulatively. Okay, so we're moving forward with, I think, once activated, we're doing pretty well at meeting those. I think the issue is that pre period as we move forward. Yeah. Well, I think that's because the docs are ordering in addition, right? So in addition to what we're proactively, well, sorry, that's a mix of patients. I'll show you the trauma and the non-trauma in a second. Maybe we can come back to that, Richard. So this shows that same type of graph now that we've excluded the patients who got no plasma, and about 84%, well, in that initial 120 minutes, in that initial 2 hours, about 80% of the patients achieve this foundation ratio of 2 to 1. I think that, the clinical circumstances change and they may back off on the plasma in some of these patients as the bleeding subsides and so forth. And then the bottom graph shows the percentage of patients that achieve the ratio of 1.5 to 1 over time, 40% by 2 hours. So I want to show you trauma patients quickly. And so these are patients. The MTP was activated. They got 3 or more units in the first hour. We had excluded those 8 trauma patients that didn't get any plasma, who died before they could get plasma. So we're left with 38 trauma patients. Okay, and this is the same kind of graph I've shown you already in terms of the cumulative, the average of the cumulative issues over time. So same pattern, achieving a more balanced ratio by, we're starting to see the plasma and platelets really kick in at 30 to 60 minutes, and then I think we're getting to an appropriate at least foundation ratio at 60 to 90 minutes, and this is cumulative, okay, including the pre part of the discussion. This shows their ratio. The ratio issued over time. So in that pre, we're obviously issuing a lot of red cells and very little plasma. But during the subsequent intervals, the ratios go down to 1.6, 1.5, and so forth. And then there's that catch-up period in the 60 to 90 and 90 to 120 minutes, where we're giving, plasma in a ratio of 1 to plasma for every 1 red cell. And that reflects these trauma patients. Then they're all basically starting in emergency. So this is a reflection of our ER protocol, really, in the push and the additional ordering by physicians. Okay. So this is their cumulative ratios over time, which basically taking us 60 to 90 minutes to get to that foundation ratio of 2 to 1. And then this is the excluding the pre. So excluding the pre, we're getting to that foundation right away, right? We're getting to a ratio of less than 2 red cells per unit of plasma right away. But many of these patients have received, a number of red cells prior to the activation. Okay, and this is the cumulative graph again for the trauma patients. So a little more aggressive with the plasma in these patients, and by 84% by 2 hours have received a ratio of at least 2 to 1, and you can see the 1.5 to 1 on the bottom. And this, I just wanted to show you their INRs. I mentioned that in the ER protocol, we have an order set that, there's a baseline QAG and rapid metabolic profile and so forth. And then at 30, 60, 90, and 120, there's blood work ordered. It's not always collected, right, for a variety of reasons. It's, there's too much going on. The patient's moved to interventional or whatever. But this just shows you, and the blue bar shows you, out of these 38 patients, the blue bar is really the number of patients at that time interval who had an INR. And then the yellow bar shows the patients who had an INR less than 1.5, and the red bar, patients who had an INR less than 2. So really, an INR of less than 1.5 is a great endpoint, really. I think, you know, that should be adequate for normal hemostasis. And so you can see that a fair proportion have that. We're falling a little bit behind, ironically, at a time when we're all you know, that in that 60 to 90 period, and the 30 to 60 period, in terms of the proportion that have an INR less than 1.5. And it's ironic in that that's when we seem to be issuing the most plasma. So, and then I'll just show you the non-trauma patients, which is probably patients that either, you know, have, well, I'll show you what their diagnosis is. I don't know if you can see that. So 13% AAAs, 23% cardiac surgery, 14% GI bleeds. There's 7% obstetric hemorrhages. There's 11% neuro surgery related hemorrhages, and 7% general surgery, some vascular, and then some medical patients with sepsis and presumably other issues going on. Pneumonia, and really bad pneumonia probably. So, no, so here's the issue. These are the non-trauma patients showing much the same pattern. So this is, you know, these are patients in whom we're not pushing the plasma from the TM. We're not pushing it. You're ordering it basically, or the ICU docs or whoever's ordering it, and we're seeing similar patterns, reasonably good, really good ratios over time in terms of the products that we've issued. If you look at their cumulative ratios, they're actually probably, I think I have a chart that compares both the trauma and the non-trauma, but really good, steady improvement as we move through. So this is cumulative what these patients have received over time. And here's the comparison of the two. And actually they're quite similar. Yes. Mm-hmm. Yeah. What's the yeah. Mm-hmm. Yeah. Yeah. So I think that when I'm showing this information, I'm really trying to get us, you know, I haven't really been able to drill down on those individual patients and look at how their care's changed over that period of time. So it is quite a crude analysis in that sense. Yep. Yeah. True. Yeah, so that threshold was defined in that trauma study where they meticulously um, looked at the charts, and I think it was 3 units infused in an hour, in a 1 hour period. Yeah. So not necessarily initiated in a 1 hour period. Yeah, exactly. And so, you know, it's really, without doing a really thorough chart search, what we tried to do is just we tried to identify patients in whom 3 or more units were issued in that first hour. So yeah, it's probably quite a heterogeneous cohort of patients, and it probably doesn't reflect the things that you mentioned, that some of these patients their clinical status may change, there may be control of bleeding and then loss of control and so forth. Yeah, so it's, that's one of the limitations of this study. So this just looking at the two scenarios in aggregate, these two groups seem to be fairly comparable in terms of the ratios of red cells and plasma that they received. So the trauma patients, where we have this push mechanism, and the non-trauma patients in ICU and the OR, where you're pulling products from us, right? So here's the non-trauma patients and their INRs. I don't know why, but there's less a lesser proportion of these patients who've achieved an INR of less than 1.5, which I'm not sure if I understand why that is, but that's probably the patients that you're dealing with most. Well, you deal with the trauma patients eventually as well. So some of them, some were cardiac surgery, some were GI bleeds, some were sepsis. So, they were bleeding somewhere, probably. But yeah, there was general surgery, cardiac surgery in that group. So here's the two charts just to illustrate. Yes. Is there a good proportion of patients switch?
In both the trauma and non-trauma who do not have INRs done in the first 24 hours despite the massive transfusion, because they pass on?
Yeah. So in the ER we have this order set, and if the patient's accessible, our lab assistants are there and they capture these measurements at 30-minute intervals. In the non-trauma patients, it's entirely dependent on whether it's been ordered. And you can see that they're not, the scale for these graphs is really, for the non-trauma, there's 44 patients. Less than half of them are having INRs at any given period. Okay, so I just want to move on now quickly to talk to you about this pre-printed order that we've been developing over the last year. And so our experience, Wynn and I and others here at RCH, is that we have so many massive hemorrhages at RCH that everybody's sort of geared up to deal with them. Sometimes on a medical ward or whatever, they're not. And so what we've observed over across the region is that awareness of the massive transfusion protocol, which really is the de facto massive transfusion protocol regionally, based on the laboratory guide. The awareness is variable across the region. There's always staff turnover, so even here when we have new people coming on board, they're not necessarily familiar with the protocol. And the ER protocol in Emerge is not always easy to find, and it's certainly not easy to find. It's not easy to find anywhere else because it doesn't exist outside of emergency at RCH. So what we've observed is outside of RCH in particular that we're having periodic critical events where they're falling way behind in terms of plasma and or platelets and cryo. There's some other things that have changed too in terms of the fibrinogen threshold, and I'll mention that as we continue. So we started work on this 18 months ago now, actually, and partly it was precipitated by the fact that we realized that there needed to be something out there, but also critical care and perinatal group had begun working on their own sort of, massive transfusion order sets or protocols. And so I worked with our laboratory scientist and Wynn Thomas here, our manager of transfusion, and regional nurse specialists from ER, trauma, perinatal, and critical care. And it's with their wisdom, actually, it was very, it became obvious that the most expedient and the most beneficial way to go about this was to develop a pre-printed order. And the reason we went with the pre-printed order is that it would be, once it's through the pathway of approval of professional practice, it's available on all wards, all emergency departments throughout the region, all wards throughout the region. And it's accessible, easy to find. And it also standardizes expectations. So you've asked about our capabilities at Eagle Ridge. I'll touch on that. But our expectation is that regardless of where a patient experiences this, that the ward can activate this protocol and understand the orders and their responsibilities. So we debated about whether it should be separate orders for emerge, for trauma, for obstetrics. We decided that a single pre-printed order incorporates all the same principles for the management of these patients with some little variation in terms of obstetrics and trauma versus other types. So the content is largely based on the RCH ER protocol, and basically what we're moving forward with is this sort of push methodology of tracking the components in the TM department in the lab and proactively issuing plasma, platelets, and cryo. So this will be, and we need to talk about that in terms of how we're going to, whether that's what you want in the OR, but this is what we plan for everywhere outside the OR. And we've raised the fibrinogen threshold to 1.5 grams per liter. That historic threshold of 1 gram was probably too low, and this is more in keeping with what has evolved in European massive transfusion scenarios. And when you look seriously, critically at the less than 1 gram, it's really based on observational data from some time ago. So the new threshold is going to be 1.5 grams per liter for generally speaking, and for obstetrics a higher threshold of 2 grams per liter. So it looks like this. It's a pre-printed order on the front, and on the back are the roles and responsibilities of all the people in the clinical team. And this is what it looks like, just for your information. It's in pre-printed orders, there's sort of a standard nomenclature that anything with a black dot is mandatory, and then there's some optional stuff. We purposely didn't put anything optional on this. So, everything's mandatory. We modified the criteria to incorporate this 3-unit. You can obviously activate this. You don't have to. In the OR, or you are quite capable of activating MTP when you recognize a bleeding patient like this. So this is largely for wards and areas where they're not as familiar with this. Okay. So this is the definition. This is the initial management, okay? The orders, it says call the lab, do this, do this, do this, right? If within 3 hours of traumatic injury and not already given, give a 1 gram bolus of tranexamic acid and then a 1 gram infusion over 8 hours and so forth. Okay? Some other stuff about temperature monitoring and so forth. And then there's the transfusion orders, which are basically to give, you give your red cells. We give 1 unit of plasma for every 2 units of red cells, but for trauma patients, we want to aim for a ratio of 1 to 1 early on. And then 1 unit of platelets for every 6 units of red cells, which is a more sort of balanced ratio of that. 10 units of cryo if the fibrinogen is less than 1.5, less than or equal to, and less or equal to 2 in obstetrics. And then, but it's still the responsibility of the physician to order additional red cells. You have to order the red cells and additional plasma or platelets as required based on what you're seeing with. Okay, so then there's some ongoing lab tests and ongoing care, and with the goal of repeating these frequently. And there's a yes. So,
Doug, how are we going to incorporate point of care testing, which is now just winding its way through the last stages of the point of care committee? Because ultimately, that is the paradigm of 2016, is point of care is probably better than INR, PTT, and fibrinogen count in terms of real time, certainly in the operating room. And so I don't see anywhere on there how we would communicate with the lab. So when I push out education materials to our department in 2016, there might be a disconnect there. So how will we bridge that?
So I'm anticipating that testing will only be available in the OR, at least initially, so I don't know, and in fact this pre-printed order, the principles of this, I think is what we need to incorporate into the operating room. A separate, I'm assuming that you're not going to be using a pre-printed order in the OR. but you are likely to have a critical care pathway, like I don't know what they call it, I don't know if it's the Harvard guide or whatever guide that people use for critical events in the OR. I think you probably have a binder or a booklet or something. The idea would be to develop something with people like yourself in the OR, a critical pathway for the OR. And I think that's where we put the ROTEM piece into it.
And when you use the term point of care testing, you're really referring specifically and only to ROTEM.
I'm in this instance referring to rotational blood.
You're still going to do other blood work.
That's a bit of a different issue than
Yeah.
point of care testing.
Point of care, just.
And in fact, to emphasize that point, that was actually, there was a lot of discussion about TEG and ROTEM at the 2011 consensus conference, right? And in fact, that was part of the Canadian consensus recommendations, is that you establish this foundation ratio of 2:1, and then you monitor ongoing therapy with either point of care testing, viscoelastic testing, or conventional lab tests. So I think it's a very good point. It needs to be part of whatever we develop for the OR. This is what it looks like on the back, and it's just broken into the responsibilities for each group. So this is the most responsible physician. The physician has to declare activate the protocol, order the red cells as required. The idea is that we will push the plasma and at a foundation ratio, and you can always decline it. But I think where this is going to have its greatest impact is in those areas where they're not dealing with these frequently, in the ER departments at other facilities, for example. And it has had, I think, an impact here, I believe, as well. And when you looked at the data that I was showing you, the OR, particularly here, seems to be pretty on top of requesting plasma and platelets. So that's a question we need to address as I bring together a group of anesthetists and surgeons in the OR. Is this something you want? Do you want us to be pushing? This is something we see as having a real benefit outside of RCH in particular, and particularly outside the OR. So, and then this is just more of the same, okay? And more of what we talked about. It informs people about their responsibilities. The nurse, the primary RN, the charge nurse, the designated communicator, and so on. And then in the TM lab, essentially what we've been doing for the last 10 years, except that now we're going to be pushing the products. And I think that's that. So what's new is that the criteria are new, the tracking in the TM lab, the proactive issuing of components, and the higher threshold for fibrinogen, incorporated a statement about calcium gluconate as well. And then you wanted, did you have a question?
Yeah, this goes back to Tim, I think, suggestion about how good fresh whole blood was. If you're going to go to a 1-to-1 ratio, I know the answer to this question, of course, but are you going to go to a system of providing us with the stuff mixed from the lab?
No. So,
why not?
But I don't want to necessarily convey the impression that I'm promoting the idea of a 1-to-1 ratio, because I honestly don't think that that's appropriate for the majority of massive transfusion events. But I think that in trauma in particular, because they have an unusual form of coagulopathy, it's not just dilutional and consumption and hypothermia and acidosis, it's the addition of fibrinolysis because of the tissue damage in trauma. And so I think that even though much of the evidence for 1-to-1 ratios is retrospective, and the recent randomized controlled trial didn't really show a benefit per se in terms of mortality for 1-to-1 ratios, I think what I'm seeing is that we're falling behind in some of these patients, and I think it's more important in trauma to get that in there. I still believe that a foundation ratio is important, though, because not everybody's on top. Sometimes when this happens, people are preoccupied with everything about caring for the patient and don't remember to order the plasma. So that's kind of the idea. So we still, at Eagle Ridge, someone had asked me about this, and so what we have at Eagle Ridge is we do the group screens on site. We have an inventory of red cells on site. I'll show you, I think I have a slide that shows you the inventory. Maybe I forgot to put it in. But if a patient has an antibody, we perform the antibody identification over here at RCH. So that can always be an issue in a massive transfusion event in a patient who doesn't have a pre-op group and screen. But if the patient has a group and screen and there's no antibodies present, Eagle Ridge is capable of activating a massive transfusion protocol. And they have red cells, plasma, cryo, they have 7A, prothrombin complex concentrates on site. We provide their platelets. So the key at Eagle Ridge is early recognition and early activation so that they can ask for platelets from RCH. Okay? And they're all trained in the massive transfusion protocol. They don't see it very often. So this is an issue that we try and annually maintain everyone's competence, but it's still a crisis scenario, and it's still, the less often you do these things, the less comfortable you are doing them, and in some ways less able to meet the same turnaround time. So it's really important to activate it early if you're at Eagle Ridge. And there's your inventory of red cells, and this is what we use for inventories at all hospitals. Not these numbers, but this concept. We have a critical level. If our red cells fall to that critical level, they order red cells immediately by cab from either CBS or the closest, usually from CBS. In the event of a massive transfusion, they would order from the closest hub site. But the critical level for OPAWS is 4 units. The routine level is 12. So that's the routine level that we would maintain. 12 OPAWS, 3 ONEGs at Eagle Ridge. And so that kind of gives you a sense of the inventory. If you've got a bleeding patient who's an APAWS, we've got 8 we could give A neg. There's 2 of those. We could give any of the O's, right? So, but they can also get red cells quite rapidly but this inventory is really dictated by their usual transfusion. So, you've touched on an important question, and that is that we try not to overstock, because then you just have red cells sitting in inventory, they're aging, and then they're not, and then who gets the ones that are older?
Here. We do.
You guys do, right? So
over here.
Yeah.
So they know it'll get used.
The RCH will want
That's
them.
common.
You're going to have tomorrow.
And then finally, I just want to preach once last time about coolers, and I've probably talked to you about this before, but really, when we introduced coolers, they were intended as to be used in massive hemorrhage in particular. So they're validated to maintain red cells less than 10 degrees and not freeze them. So between 0 and 10, but that's not the optimal storage temperatures for red cells, right? The optimal storage temperature is 4 degrees. So our fridges keep them, within 2 degrees of 4. And when we put them into the cooler is validated to hold the temperature. 0 to 10 is the standard for transport of red cells. So for red cells outside of that range, you have to discard it, right? And so it's not optimal. And so what's happened, though, is they gradually become more routinely used in smaller numbers of units. And this is an old audit from 5 years ago, but this was in a 3-month period. We had issued 144 coolers here at RCH. This is I think a heat map is probably the best way to describe it, showing on the left side, the numbers, on the top, the number of units issued, and then on the left side, the number of units returned to TM after the surgical procedure. And so you can see, where we've issued 6 units, we typically will get back 1. We might get 1, or if we, but the thing I wanted to focus on here is these 2-unit coolers, and overwhelming, a large number of these 2-unit coolers are coming back with 2 units in them. And then I want to show you this. This is a measurement of temperature of the red cells upon return. So we've noticed recently in particular, so we haven't repeated the audit, but we're getting some temp units back that are out of range. So they're more than 10 degrees and we have to throw them out. And